So SARS-CoV-2 and its associated disease, COVID-19, has had a significant impact on transplant patients. Mortality rates as high as 32% have been reported. The presence of COVID-19 antibodies and their levels in transplant patients is critical in assessing risk for transplant procedures. High-risk patients may need higher levels of immunosuppression and would be a greater risk to COVID-19 and false negative tests. So our initiative has been to test for multiple COVID-19 targets that will help increase the accuracy of antibody testing and improve the ability to interpret outcomes from this testing. And it also utilizes a common platform for testing in transplant labs, namely the solid phase single antigen bead testing for HLA antibodies. The LABScreen COVID Plus Antibody Assay addresses an unmet need. Most antibody assays for COVID identify a single target, maybe two targets at the most. And because of this, they can deliver false negatives by not targeting the correct antibody, or false positives due to cross-reactivity to common cold coronaviruses. The LABScreen COVID Plus Assay applies a multiplexing approach to deliver a more comprehensive picture of the patient's antibody profile. This more comprehensive picture is provided by targeting 5 unique anti-SARS-CoV-2 antibodies. In addition, 4 common cold antibodies, the MERS antigen, and SARS antibodies. The test has provided 100% sensitivity and specificity to reduce false negatives and false positives. It utilizes the XMAP technology, which is the gold standard for multiplexing. Requires only 2 to 3 hours of turnaround time on either the LabScan 200 or LabScan 3D systems. Therefore, it is more accurate, efficient, and cost-effective than testing for these targets individually. Potential examples of situations in which antibody detection with a LABScreen COVID Plus assay may be utilized to detect whether patients have antibodies following a COVID infection. It's known that not all patients develop antibodies post-infection, and particularly those that have minimal symptoms or an asymptomatic infection. It can also be utilized to determine whether or not vaccines have resulted in the generation of anti-COVID antibodies. This is particularly important in transplant patients as they are immunosuppressed and therefore are known to have reduced vaccine responses. It can be used to quantitate antibodies in patients that receive passive prophylaxis, for example, with convalescent sera, or with one of the new anti-COVID antibodies that can be given for passive prophylaxis, including bamlanivimab, the Lilly monoclonal antibody, and also the Regeneron cocktail. And it can also be used to define the nature of the antibody response, whether there's neutralizing or non-neutralizing antibodies. The detection of antibodies against RBD would give a higher likelihood of developing a neutralizing antibody response. So when this came about, investigators who are listed to the right here from Emory, University of Cincinnati, Stanford, and University Health Network worked together collaboratively with Thermo Fisher to develop this multiplexed assay. This was recently reported and published. The generation of this assay and the validation of it were published in Transplantation. Features of this assay, as we've mentioned, it's a multiplexed panel. It provides antibody response against the following 5 SARS-CoV-2 antigens: the whole spike protein in a trimer fashion, S1, S2, RBD, and nucleocapsid antigens. It also, as we've mentioned, the common cold, MERS, and the original SARS-CoV-1 antibody can be detected. And it's available on both platforms, 200 and 3D platforms. It can eliminate false negatives, provide deeper antigen coverage as compared to a single or duplex detection method. It can detect and benchmark against a prior coronavirus exposure with a common cold coronavirus. Importantly, it can differentiate antigenicity along the spike protein or the nucleocapsid protein, which can help determine whether or not patients have developed antibody responses which are therapeutic or can be deleterious to patient outcomes. And it can also help distinguish the immunity efficacy of the vaccine and also its durability. One of the issues about immune responses, particularly humoral responses to SARS-CoV-2, is that they're known to not necessarily have substantial durability, certainly not along the lengths of durability that are known for measles and mumps vaccines. And so this is a cartoon demonstrating the presence of the virus here. As you can see, the structural spike protein is the major structural protein. It's the major antigenic protein. It's located on the outside of the viral envelope. And the nucleocapsid protein is actually an internal protein, and its use is, its function is actually to encapsulate the messenger RNA nucleic acid material of the virus. This is a cartoon pictorial version of the spike protein. The S1 portion of the protein, S2, and the RBD are shown here. The RBD is the receptor binding domain. It's important because it's the portion of the antibody that recognizes the human ACE2 receptor. It has also more recently become important because of the detection of mutants. The majority of mutants, mutations that tend to occur in the SARS-CoV-2 genome are concentrated in the RBD region. And therefore, the ability of a neutralizing antibody to retain its neutralizing capacity depends on these types of mutations, and they can affect that. And this is something that the antibody, that this antibody detection platform will have the ability to rapidly adopt new mutant versions of the RBD protein, something that's currently under development with substantial progress already having been made. So here are the beads, negative controls, positive controls. Spike protein, whole spike protein, spike S1, spike RBD, spike S2 nucleocapsid, 4 common cold coronaviruses, the MERS spike protein, and the original SARS spike protein. Now I'd like to show you a few results that have been obtained with actual patient samples. This is a patient that has demonstrated positivity across the spectrum of SARS-CoV-2 proteins. Here's your this particular bead and histogram, bar histogram is the whole spike protein. This is spike S1, this is RBD, spike S2, and this is nucleocapsid. As you can see, this patient developed detectable antibodies exceeding 12,000 MFI for all of these proteins. The whole spike protein was actually positive at 62,000 MFI. These are the 4 common cold coronaviruses, indicating that this patient is like most people in the human population, that they have had previous infections with 1 or more of the common cold coronavirus proteins. And this is the original spike S1 from coronavirus. Let's go to the next one. And this is a patient who turned out to be positive to SARS-CoV-2 spike S1 and RBD, what was negative to spike S2 and nucleocapsid. Some patients don't respond to nucleocapsid. These patients tend to have, this is a good profile for protection, having a lower nucleocapsid. Nucleocapsid, as you know, is an internal protein and therefore is unlikely to be blocked from binding by this protein. And then here's your common cold coronaviruses. Patients who do not do well, who tend to get more ill, actually tend to develop greater responses to nucleocapsid than they do to the spike protein. And this is one of the characteristics of human responses that's been published and reported for patients who have more severe COVID disease. And this is a patient that has no SARS-CoV-2 antibodies, has had prior exposure to the common cold coronaviruses, but not to the original SARS-CoV-1 or to the MERS virus. So this was a patient that was actually received a vaccine through the Oxford vaccine. You can see this generated a response to spike S1 and RBD, with S2 and nucleocapsid being negative. Nucleocapsid would be predicted to be negative because that protein is not encoded by this vaccine. This is a whole spike protein vaccine. And again, this patient most likely had pre-existing immunity to common cold coronaviruses. So this is an example of how the multiplexed assay can give you an idea of the response to the vaccine in terms of the nature of the antibodies that are produced. Well, what can we do with this assay in the future? Is there other additional types of information that can be gained through future iterations, or also potentially via people who are using the assay for research purposes? One of the things that may be of interest to people who like to understand the nature of the antibody response, what are the characteristics of an antibody that's protective? What are the characteristics of an antibody that may be injurious? And there's physical characteristics where you can look at the antigen, the epitope specificity, the immunodominance, affinity, and avidity, isotype and isotype subclass. People can also look at hinge region glycosylation, or has been done for HLA antibodies on the similar platform. People can look at complement binding, FC receptor binding, receptor signaling, and antibody antigen complex mediated immune regulation. So I'll show you a few examples of how people have done this. So in addition to future iterations of the assay, additional antigenic targets can be evaluated. There are additional structural proteins, envelope and membrane proteins that could be added. There's actual non-structural proteins, including ORF3b and ORF8, which appear to be potentially promising. And then there's also the possibility that when mutants emerge, as I mentioned before, these mutants often have mutations in the RBD domain. So one can actually take a mutated RBD protein and add that on a bead so that one could look at whether or not that patient's antibody profile actually, and its binding to RBD, is affected by these mutations. We can also look, as we mentioned, antibody isotype, antibody subclass, like IgG 1, 2, 3, and 4. One can look at IgG or IgM. And then one can also look at the ability of the antibodies against a specific SARS-CoV-2 protein, look at the ability of those antibodies to bind Fc receptors, which would be important for opsonization, and also other mechanisms of viral clearance. And then one can also look at the complement binding capacity. So this is the SARS-CoV-2 proteins. There are functional proteins and structural proteins. The 4 structural proteins are shown here: spike, nucleocapsid, which are both tested in the assay, and then envelope and membrane proteins. These were not included in the assay. They appear to be of lesser importance, but it's certainly something that could be included in the assay in future versions. Then there are a number of structural proteins here. And of these structural proteins, some of them appear to be more useful and diagnostically than others. This is a paper from Nature Medicine, which used IgG and IgM levels of SARS-CoV-2 antibodies. As you can see here, some patients have IgM seroconversion earlier than IgG. And some have IgG seroconverting earlier than IgM. As you can see, the IgG went up to higher levels earlier, okay? And some patients actually have IgG and IgM appearing simultaneously. And so what this indicates is that the usual rules for an early IgM spike followed later by an IgG spike do not necessarily occur in patients that have SARS-CoV-2, indicating that the normal rules, the virus doesn't follow the usual rules that we have for many other infectious agents. This is actually a study that was published in Nature Communications, where the investigators looked at IgG and IgM responses. IgM is over here, and this is IgG. And these heat maps show the level of antibodies produced against these various proteins, okay? And these are each column is an individual patient. So as you can see, there's a fairly substantial response against RBD and the structural proteins here with the IgG, and IgM is shifted away from some of those proteins to where it occurs for different ones. These are patients that have not had SARS. These are actually controls. And so as we mentioned, there are a number of non-structural proteins. Each one of these graphs represents a non-structural protein in patients that had COVID-19 on the left and patients that haven't had COVID-19. And what this analysis demonstrated is that 2 structural proteins, ORF8 and ORF3b, are actually accurate serological markers of early and late SARS-CoV-2 infection. And what these are actually assays that have already been developed and can be included could be included in future versions and future iterations of the COVID antibody assay. So complement binding is something that's been used. C1q binding has been used to analyze HLA antibodies and their functional properties. And in an identical way, C1q binding can be developed to determine whether or not antibodies detected in this multiplexed assay against COVID have the ability to bind complement. We've also developed in our laboratory an FCR panel where the ability of a SARS-CoV-2 antibody or an HLA antibody can be tested for its abilities to bind specific FC receptors, like important FC receptors, like the high affinity FC receptor expressed on macrophages, or maybe the FCR3, a CD16 antibody, which is known to bind to FC receptors located on NK cells. And finally, this is some work that has come out of Galit Alter's lab, where she looked at a more comprehensive way at not only antibody isotype, antibody ability to bind complement or FC receptors, or neutralizing capacities. As you can see, these are all violin plots showing activities against spike, RBD, and nucleocapsid antigen for IgA antibodies, IgM antibodies, and also IgG. And then these are actually functional assays that they looked at. This is antibody dependent cytotoxicity. This is an NK mediated assay. And this is antibody dependent cellular phagocytosis. And so this illustrates how these types of multiplex assays can actually give you information in a global fashion regarding the functional capacity of an antibody. And these are from the same paper with data presented via a Nightingale plot. And what they did is they looked at convalescent patients and compared them to patients that did not survive COVID infection. And they looked at their global antibody responses to spike protein, RBD protein, and nucleocapsid. And what they found, as you can see here, that deceased patients tended to have bigger antibody responses to nucleocapsid, that they had a very wider variety and higher levels of isotypes, that the cellular function was also more important. But if you look into convalescent patients, these activities were largely directed to spike, indicating that the neutralizing activity of an antibody profile in a patient tends to correlate with whether they survive or expire from SARS-CoV-2 infection. So in summary, antibody responses to SARS-CoV-2 in humans demonstrate considerable heterogeneity with the type of antibody, its functional capacity, and its levels. That antibodies responses also differ between people who are asymptomatic and people who are symptomatic. And antibody responses also differ between survivors and non-survivors. And with that, I will close, and I'm happy to entertain any questions.